in our clinic, I was seeing patients when the MRIs are horrible, serious conditions, but the patients don't have pain. And then you have some patients who have excruciating pain, and you do the scans and there's nothing physically or visually wrong. So then I was like, well, clearly it's a brain issue.
Dr. Wayne is a best-selling author of Why Movement is Medicine. He is an award-winning chiropractor who served as the team chiropractor for England at the 2014 Indoor Cricket World Cup, and he is the founder of MoveMed, where movement is medicine.
Physically moving the body as a treatment is great. It's teaching the brain how to move again. Just a random treatment or a random anything feels nice short-term, but essentially it's just trauma to the brain, and the brain's going to feel great because you physically got the body moving a bit. But if it's like a once-off thing, the long-term effects are actually...
Hi, my name is Chris Burris. I'm a longevity expert and the chief scientist at a lab focused on a longevity molecule. My primary focus is to help people live longer and better lives with science. Make sure to subscribe and share so you and your friends can live longer and better, well, actually, so you and your friends can live beyond the norms.
Hi, and welcome to the next episode of the Live Beyond the Norms Health and Longevity Podcast. What if your pain isn't just hurting your body? What if it's hijacking your hormones, wrecking your sleep, draining your energy, and aging you years faster? Most doctors just numb pain. The truth is, chronic pain is a cycle that rewires your brain into fear, stress, and shutdown. Dr. Wayne is here to show us that you can break the cycle, and movement is the key. A little bit about Dr. Wayne. Dr. Wayne is a best-selling author of Why Movement is Medicine. He is an award-winning chiropractor who served as the team chiropractor for England at the 2014 Indoor Cricket World Cup. That's pretty awesome. His degree is from Durban University of Technology, and he is the founder of MoveMed, where movement is medicine. He has more than 600,000 followers on Instagram, and he created the NRE Protocol. That's the Neural Re-Education Protocol. His mission is to help people understand that applying neuroplasticity principles to chronic pain management and movement longevity can break the cycle. Hopefully, we can help him with that mission today. Dr. Wayne, thank you so much for joining us today.
Chris, thanks so much for having me. This is awesome.
So before we jump into your area of expertise, I like to go further back. I like to go much further back. What was it like growing up little Wayne? And it's Cuan, I think is your actual first name. Where did you grow up, and what were your parents like? If there was some event or someone you could pinpoint as the reason you would ultimately become an author, a chiropractor, and now an influencer, what or who would that be?
Big question. So I grew up in South Africa, on the East Coast, a town called East London. It was there where I was training for triathlon. I was about 16 years old. I got hit by a car, nothing too serious, but I needed to see a chiropractor urgently to get better for the upcoming national champs. So that's how I met the profession of chiropractic. And I was helped very quickly, and I got back on track, and I eventually made the team that year, which was pretty cool. So that's how I met the profession. And then, my brother and I are both in the medical field. My brother's an orthopedic surgeon. When I finished school, I was a bit behind him. I had a choice of like chiropractic, medical, doctor, physiotherapy, etc. And I just, the doors opened up wide for chiropractic, and the rest is history.
Are your parents, were mom, dad, what were their influences? Were they kind of in the medical profession, or what did that look like?
Yeah, so not at all. My dad is an engineer by trade. He ended up becoming an engineer from years of being a technician. And my mom was a full-time mom. She was a secretary. And it was always her dream to be a doctor. And her parents couldn't afford to send her to university. There's a very sobby story. But so I think my brother and I are living out my mom's dream in a way. So I think the deep down passion came probably from my mom's influence.
Very cool. All right, so you got your doctorate in 2013. You're lecturing at the University of Pretoria, and then quickly you are the team chiropractor for England's indoor cricket. That all seems to happen really fast. Like, talk a little bit about that part of your journey.
Very much a right place, right time. So in South Africa, the degree is a master's degree. So you finish with a master's, but then you get the honorary doctor title as being a doctor of chiropractic. So that was that. Then I took an internship with a physiotherapy practice in Pretoria at the University of Pretoria. And while I was there, the doctors specializing in sports medicine needed a chiropractic lecture done. So it was just right place, right time. So there's a fresh, brand new grad lecturing qualified doctors. So that was pretty daunting. Probably the most nervous I've ever been. But yeah, then from there, again, right place, right time. The England Masters team was traveling to South Africa for their World Champs, and I had lots of free time. When you're starting out, you have lots of free time. So I was with this team for a week. I impressed them, and it was the same manager the following year who was with the senior side, and that was to New Zealand for the World Champs, which was really cool.
Yeah, very good. Did you play cricket growing up? I think it's certainly more popular in South Africa than here in the States.
Yeah, so I have got no ball skills. I was an endurance athlete. My brother and I ran and did triathlon and things like that. Probably just a sports fan. So yeah, when any national team comes on knocking, then you just say yes.
So you have a little bit of a personal story you share, and maybe you've already shared kind of you just had some exposure, but from athlete to author to clinician, has any of this shaped your approach to how you manage pain and performance with your current client base?
Yeah, it's a good question. So I've been very fortunate to have been an associate in multiple different practices, different styles of practice. And they are always learning curves. You take on some things that you inherently agree with. You might not agree with some parts. So I think I've had enough experience with different styles of practice, and that was when I started to think about the NRE protocol. Was something was missing. Either patients were coming in with pain and just staying for pain treatment and then stopping coming, but then they were always coming back in pain. So clearly something was missing there. And then to try and catch people to come in for almost like check-ins without having the pain, there was some kind of missing link. So generally most people find you because of pain. And now just with the way that we educate things, the patient retention is pretty good, as in people come back because they want to come back, because they can see a benefit of maintaining things as opposed to creating a dependency. So yeah, it's all kind of merged over COVID time, I suppose. COVID was when I wrote the book. I just moved to the UK. I was on a work visa. So I had this free time where I was not a chiropractor for a few months because we weren't able to physically touch people. So yeah, I had this draft of a book on a cloud somewhere, and literally the day the lockdown started, I started writing. I got 2 different editors, and the rest is history.
Very cool. Yeah, I think the editors are credited in the book. I kind of leafed through some of it. So how much of the book was done, had been in draft, and what does even the process look like of kind of jotting these notes down as you're kind of practicing?
So I had this cloud draft of just stories of just, because I'm sure many people in every field, you'll have a great idea or you have a great experience and you think, I must write this down. So I actually did start writing things down. So I had this library of just patient interactions, funny stories, serious stories, sad stories, even just thoughts of my childhood, where you just make notes of them. So I had this library of just ideas and thoughts, and then I did the book the wrong way. So I had chapters with no plan. I think most authors they have a plan, then they start writing. I started writing with no plan. So the book is a little bit of a mixture, a little bit of personal stories, a little bit of clinical stories. But yeah, it's pretty cool.
Yeah, that is pretty cool. It sounds, so I wrote a book also, Live Longer and Better. And my story was I found a co-author. I thought he was going to do everything. And then I was going to go, yeah, that's a great book. And then in our first meeting, he said, Chris, I need to write down all your thoughts. And then I was like, apparently I'm writing a book, right? And it felt very much like what you described, so maybe there was a little bit more thought of that it was actually going into a book as opposed to over time sharing ideas. but I really was, kind of brain dumping the experiences that I had and how they might all tie together into this book. So I think there are some really good parallels, right? So you've got this NRE protocol. Do you remember like the first time that you really started thinking differently and that you needed something that even needed a different name?
Yeah, so the NRE protocol I have not created a new science. I haven't done a PhD on it. It's a protocol that any practitioner who's in the sort of manual therapy field could like follow. It's just a like series of steps. So sometimes you have these brilliant clinicians, but there's no sort of system for them to work on, So there's so many different styles out there, and I think I mentioned that I've experienced a few different styles. So I just wanted to bring to the table some kind of plan that people can start from sort of level or like layer 1 up to like layer 10. And I would say it probably hit home to me that in our clinic I was seeing patients when the MRIs are horrible and there's just a lot of gnarly changes on the discs or whatever, like serious conditions, but the patients don't have pain. And then you have some patients who have excruciating pain, and you do the scans and there is nothing physically or visually wrong. So then I was like, well, clearly it's a brain issue. So I think we all know that now. I think it's like pretty accepted that pain is obviously a sensation in your brain. It's always real, but it is in your brain. So yeah, now I just found that there was like a bit of a gap between educating that to a patient, however, trying to physically treat them, and there was just some kind of link missing. So we've just put it together as a protocol, and hopefully we'll be able to teach some courses on it. And there's a few practitioners reaching out, like where can they do courses or certifications, and that's all future plans.
Very, very cool. So how might you describe this as being different, right? Because you said that every practitioner can do it. It's more of this guideline. Is it are some practitioners putting the cart before the horse, and that's part of what this protocol is like, let's get the horse in front of the cart, or are there actual kind of how would you describe this as being different?
Yeah. So, for instance, in the sort of chiropractic profession, you could see someone and see a chiropractor the same day for the same condition, and you might get a different opinion, a different treatment plan, different recommendations. So that's standard across all fields, right? You'll see two doctors, two physios, two osteopaths, and they will give you just different opinions. So that is the reality. What I'm just trying to bring to the table is focusing on giving a patient hope. So even though the changes and there might be some serious things happening, you can educate a patient in a uplifting and a positive way, as opposed to a demeaning and a like way that makes a patient dependent on you. So that's kind of the gist of it, is that we're like trying to give patients hope that no matter what is happening, we have a plan to get you out of pain. And then the second phase is the longevity side, where we're just trying to keep you moving long term.
Very cool. So what are the biggest signs that someone's pain is actually coming more from kind of neural dysfunction rather than tissue damage?
Yeah, so with an assessment, we will be doing orthopedic and neurological, like a full orthopedic and neurological test. So some patients will have a specific neurological symptom, whether it's like the numbness, tinglings, burning, shooting, or nerve tension specifically. Obviously, like that is then you're treating a nerve issue. Some patients the clinical picture doesn't match what they're saying. So they'll say that they have excruciating pain, etc., but then on your physical findings, they actually seem pretty good. That kind of makes you think, there's some kind of central sensitization episode. Something is making this person's brain experience more pain than they should. And then it's almost like your treatment can almost focus more on education as opposed to hands-on. Sometimes for the more people, the people who have more orthopedic and neurological testing positive, you might sway more towards hands-on treatment. But there's always a trifecta of hands-on, education, and exercise therapy. Those are the sort of big three pillars.
So How much of this is dependent on, so I hear education, and maybe this is the answer, because I will never forget when my wife was in labor with our twins, the nurse asked her, like, what pain level was she at? And I think she said at least 8. I think she said 9. And the nurse was like, most people at 9 need morphine. And then my wife was like, oh, 3. So what part of, like, and you know, I would love to be the person who is incredibly aware of his body and could tell you, like, I know when things are happening, and the evidence is is counter to that. What part of this are you kind of just maybe educating that piece, or how much of a role does that kind of thing play?
Very good question. So I think traditionally, with just how everything has been marketed, is like you have pain, then you see someone. So like pain is like the big sort of advertising symptom. But in like reality, you know, someone being a bit more moody than they normally are is perhaps underlying dysfunction, aches creeping in. You know, someone not sleeping well is a symptom to me. You know, someone not having motivation to get up in the morning, like these are all psychological symptoms, which pain is also one of those. So I think historically, pain normally brings someone into the actual room. But if someone's mildly moody, or if there's a change of character or depressive symptoms, that's probably the best time to see someone. Like, your body's probably fighting something, and it might be something physical that a manual therapist could help you with.
You mentioned dysfunction 8. I think earlier you also mentioned, like, kind of levels 1 through 10. Were you talking about kind of level? Talk about what do you see as levels 1 through 10?
Yeah. So when we speak about the NRE protocol, behind me is the remove, move. So in the most simple terms, any practitioner could probably does this. You know, you're removing the cause of the dysfunction if you can, then you're physically removing a person, and then moving forward. So that's probably the three layers if you wanted to keep it layman's terms. If you want to get deeper, then we can expand it into 10. And 10 layers starts from physically accepting that you have perhaps dysfunction that you want to fix. And then it goes into the assessments, seeing where perhaps some of the symptoms. So we speak about like mapping someone. So if I touch your skin, that should feel like a light touch, but sometimes people will experience that as pain, sometimes won't feel anything. So we like kind of map where the nervous system might be dysfunctional. And then we go up. Sort of layer 5 is treatment, essentially. Layer 6 is introducing novel and new movement patterns. That's pretty much what's dominating my social media at the moment, is these combinations of new novel movement patterns. But that's only one layer. 7, 8, we start going into speaking about the 4 pillars of movement. So everyone should be moving. I'm sure we'll speak about this later. But if you want to keep it simple, educational terms, there's 4 layers of movement. And then sort of layer 9 is we start speaking about the 5 healthy brain pillars. We can speak about that if you'd like. And then layer 10 is pretty much, it started off as Inception. I'm sure everyone's seen the movie Inception, but it's a self optimizing loop where a patient can actually look after themselves. And when they're coming in at like level 10, what's happening is that they're just coming in for literally checkups. You know, they aren't necessarily in major dysfunction, but they've been given enough tools and biohacks, if you want to call it that, to look after themselves.
So what's taken off is for your social is novel movements. Did I catch that right? What's the first one that took off? Talk about that experience, because my wife has done very well also, and so I was around for that. People always hear like, what's the first video that went viral, and like, did you go to sleep and you had 10 views, and you woke up and you had so many views? Like, talk about that a little bit.
Yeah. So again, a small personal story. Yeah, my wife and I have an 8-month-old, and I started posting 9 months ago. She arrived a little bit early, and then, long story short, I had committed. I said I'm going to post from March till December, till now, and then I was going to transition into more talking content. And the first phase, I knew I was going to have a newborn, and the idea of just posting exercise videos with descriptions sounded doable for me. So yeah, I started posting, and after 6 weeks, pretty much nothing happened. But I mean, I was like posting pictures in the maternity ward, and anyway, one went viral, and the move was a side bend. So you're you're crossing your legs across yourself, and then you're bending over the back leg. It's just a great movement. I mean, we've been doing this for like a decade, but yeah, no one has seen it on the like internet apparently. So yeah, it just took off, and I don't have notifications on my phone, and whenever I go into the app, like it just has like notifications, and I went into the app and it just at the top was like 100 comments, 100 likes, 100 shares, and I was like, what on earth is happening? And every 5 minutes you would go on and it just had 100, and it was pretty cool. But I think what helped is that I had already then 6 weeks of library of videos. So by the time someone finds one video, they're like, oh my gosh, this guy's not a nobody. He's got lots of videos. And then, since then, there's been many who are sitting in the 5, 6, 7 million views, which is, it's like really humbling for me, to be honest. I'm just giving free education, free motivational hope to people. And the comments are honestly so humbling. Like people will just like comment things. You've helped my chronic pain. 10, 20 years of pain is gone. Thank you so much. Wow. And like it really is just so humbling. And that was why I got into this profession in the first place. So it is really cool. And we're only getting started, which is also pretty humbling.
Yeah, that's cool. Yeah, it's the reason you got into the profession in the first place without the knowledge that you might eventually impact so many people. That's very cool. All right, so you talked about. I wrote a note down here. There's 4 layers of movement. What do you see as the 4 layers of movement?
Yeah. So again, I think everyone kind of speaks about these 4, but in terms of like just simplifying them, you could speak about strength. So strength is if you want to have one, so strength, endurance, proprioception, which is balance, and then mobility. So that's like flexibility, mobility, agility. So those are the 4 pillars. So I see lots of patients who are doing no exercise. So then we obviously have to have a plan, see where they can commit to starting something, But some people are already doing lots of exercise. And I think we're living in a world now where health is popular, movement is popular. So a lot of people are doing a lot of exercise where they haven't necessarily been athletes before. So they might be doing a lot of 2 or 3 of the pillars and completely neglecting one of them. And that's often what causes their overuse or dysfunction, is that they're doing too much of one thing. And then we just need to adapt and see where we can add in a few performance enhancers.
Are there any kind of tricks? Well, one, the content that you're putting out on social media, does that tend to lean? I imagine you're not doing that much of endurance stuff on there, like showing somebody jogging for 20 minutes is not a great video.
Exactly.
But so what do you tend to show there? Obviously, from what you just described, was probably more along the lines of flexibility and balance, maybe combined.
Yeah. You got all the great questions there, Chris. So literally, so I think in terms of being creative, if I posted myself walking on a treadmill, no one's going to follow you, right? So you have to sometimes catch people's attention. So the education behind the movements is powerful. So I try to find a few PMID numbers, PubMed articles to back up what I'm saying in the texts. But it's mostly just a bit of balance, bit of mobility, but it's often combination movements, and it's novel. So it's new movement environments for the brain. And I don't know how deep into the weeds you want to get here with the like neuroscience, but you have top-down processing and then you have bottom-up processing. So bottom-up is where you're changing your movement environment to teach the brain something new. And there's a few principles. If you teach the brain enough new things incrementally over time, the brain will learn it. So the same principle applies when you're helping people with chronic pain. Sometimes the brain only associates their lower back with pain, and now all of a sudden someone's doing a weird penguin movement from my Instagram, and that's introducing a endurance effect in the pelvis. And now the brain can like pick up, oh wait, my lower back can do endurance, not just pain. And eventually the brain regions are fighting for the same real estate. So if we give the brain enough of a certain stimulus, it will unlearn the pain essentially. yeah, that's probably like neuroscience 101 for pain
No, I
management.
love it. That is opposite. Are you familiar with the technology by NewFit? Their device is called Newbie. It's a DC technology, DC current instead of AC current. Are you familiar with that?
I am familiar with it, yes.
So one of the things that you talked about was like touching people. They do that with the current. I did a treatment yesterday, I think it was, for some tennis elbow issue. And what you're talking about has a lot of parallels with what they're talking about. They're really talking about neuromuscular reprogramming, and that's exactly like what you're talking about, right? But you're doing it with, we'll call it odd movements or unfamiliar movements. I think that's fantastic. Wow.
Yeah, I think the original sort of like in terms of like the first concept came out I think 50 years ago with Melzack and Wall. It was the gate control theory. So if you bump your elbow, what does your brain intuitively do? It rubs it. So you're essentially just sending a whole new stimulus into the brain to override the painful stimulus. So yes, all of these clinical tricks are exactly that, tricks to trick the brain into forgetting the pain. So yes, there are lots of, there's cool machines out there. There's lots of stimulus, hot, cold, vibrations. There's lots of stimulus. And that's where I think there's lots of noise on the internet. The voice I want to give is the voice of simplicity. So they are all really cool. And even my like demonstrations are cool, but in isolation, they are just that. They are just noise trauma for the brain. So the stimuluses need to have a bit of context sometime. So that goes back to the basics.
Can you think back, right? So you when you wrote the book, you were jotting down kind of stories of your past, but also particular patients. Do you remember kind of the first one where you're like, wow, this was absolutely a neural issue, right? And I ended up solving it or greatly improving it with kind of these odd movements. Do you remember that kind of first situation?
Yeah, I think everyone remembers their first. But yeah, so I remember it was like the first sort of eye-opener was probably my first few months in practice as an associate. And this guy came in with a cervical disc in his neck, probably I think C5 or 6, and it was a big bulge. And it was big. And the surgeon told him straight, you need surgery. And as you know, the anterior approach is they separate all of these important vessels and they literally discectomy, cut away some of your disc, or they will fuse your neck. And this guy was in his 30s, and he just came to me and he was just like, please, can you help me? And I said, well, yeah, let's try, And he just responded really well, just like one of those cool cases where he just did everything I said. And like, this is now common for all practitioners, right? Like, you can help people. It's pretty cool. And that was just an eye-opener. Like, he was just so grateful. And it was just like, not like a fake thank you, like it was like, you've changed my life. And I was like, wow, that's pretty cool. So that was probably for me, the like one. And all the whole NRE protocol goes back to giving patients hope, forming an accountability relationship with them and just giving patients hope. Hope through exercise, hope through education, and hope through hands-on treatment.
Yeah, I think even just explaining as you can, listen, right now your body is associating movement in your lower back with pain, and so anything causes pain. We're going to give you a whole lot of stimuli and movements that can help reprogram that. That intuitively makes a lot of sense, right? And so that's probably messaging. I don't know that I haven't visited any sort of physical therapist very often, but it certainly wasn't messaging that I think I ever heard. And to hear that, and of course I wasn't necessarily treating pain, although you're in some sort of pain or dysfunction as you're going in. I would have to imagine that that's really, really, really powerful, and lands really well.
Yeah, it really is. And cheesy, but I really do just enjoy what I do, and giving patients hope is like really cool. There is an asterisk here. Some patients don't respond well, right? But like that's also where you have to, like, if someone trusts you enough and you say, listen, I think that there might be something else here. We need to refer you. They'll just say, yes, thank you. I trust you. Let's go. Most mechanical things, most discs, I think discs are very common. They're very, very common. Probably something else that like you asked about, events that open your eyes. In 2017, the first big research came out about asymptomatic MRI studies. So patients have got no pain, but they MRI'd a random population. And yeah, I mean, it is quite staggering. By the age of 30, there was like, I think 30 or 40% of people with disc bulges in their spines, but they got no pain. Wow. And the graph is obviously straight linear. Like the older you get, the more stuff you find. So when I see a MRI with a patient, they might say, yeah, I have this disc and I've been offered surgeries or all sorts of treatments. And I'd be like, yeah, cool. But most of them come right on their own. And they're like, what? Or I say like 50% of people your age have a disc bulge. They're like, what? So yeah, it's just giving people hope. I think that's the main message.
Very cool. You mentioned earlier kind of around layer 8, like the brain pillars. What are the brain pillars that you focus on?
So yeah, that was from a research article 2016. It came out, I think, by Schaefer. She found, like a few pillars of a healthy brain. So basically, the godfather of plasticity is a guy called Michael Merzenich. He could basically the godfather, but the grandmother is Marion Diamond. And she did the research, this was in the 70s, 80s, that basically showed that if you nourish a brain, it will physically grow. So that was like the first pioneering study where it showed like you have a nourishing environment, the brain will thrive. And if you want to simplify those, the 5 pillars of a nourished brain, in my practice, we just summarize them as the LENS principles, LENDS, and L is love, E is exercise, N is newness and novelty, D is diet, and S is sleep. And when you say these, it's like, most of them are always like like sleep is important, diet.
What does DUH stand for?
DUH is like, obviously Cuan, like if I'm speaking to myself, I'm like, obviously, like, Cuan, don't be an idiot. So I think 4 of those are completely acceptable. Like, I think everyone accepts them. Like love, like if like people get better for people, so or for things. Maybe if people get better for things sometimes. So having an accountability or a reason to get better, patients are 90% better already. Exercise, we can speak about that for hours. The sleep is essential. I think like now it's just completely accepted that that's like the best neurohack you can get. Diet is a broad category. That could be what you do and don't eat, etc. Or the timing of your food. But then the novelty is a big one. Like people don't often think about novelty. So I'm trying to obviously teach people about a few novel movements on the internet, but novelty can be learning a different language, learning a different skill. So like introducing new and novel movements, your brain's going to always be trying to learn something new. So the brain there's always 2 things happening. The brain's trying to offload experiences to reflex. So when you like my little 8-month-old now, she's trying to like stand, and it's like if you can remember back to being a baby, I'm assuming we were all super shaky, but now we can stand without thinking about it. So the brain's offloaded standing and walking and breathing and all of these things to reflex. But if you don't introduce new stuff to the brain's got no reason to continue growing and evolving. So the novelty is very important, arguably as important as the other pillars.
Well, and I think novelty does a couple of things. As I've continued to age, you have probably noticed this too. Time seems to be going faster, although you have a little one. And I think, I don't know if I read this or is just kind of an interpretation, that a lot of why time happens so much faster is my day is basically the same thing every day, right? Like I come on podcasts, I interview people. I love that. It's fascinating and there's new stuff in there. And it's also the same stuff. And when you keep doing the same stuff, time actually goes faster. faster. And, for your young daughter, time is forever, right? Like, because everything's new. And I really think that there's a lot of, if you ever feel like time is going too fast, do new stuff. It's why there is so much value in a vacation, because vacations tend to be in new places, with any luck, with new languages, with all sorts of new stuff. So that makes perfect sense to me.
Hey, super quick break from the podcast. Hopefully you're loving it. This is a way you can support the podcast and take advantage of a great offer. We're offering 50% off of one of our MCT bottles. MCT is an amazing oil. Add the ESS 60 molecule to it. It's even more amazing. All you got to do is leave a review on iTunes, send us a notification that you've left that review. We'll get you a coupon code that'll get you 50% off of our MCT oil and free shipping. Back to the podcast.
So chronic pain affects so many different things. How do you see it affecting things beyond movement, things like hormones, metabolism, sleep, emotional regulation?
Yeah, so it affects all of the above, Chris. Like when people are out of pain without knowing it, that they might have been in the cycle of chronic pain has got the same regions in the brain as chronic depression. So people with chronic pain can be clinically, on paper, depressed, so just no motivation, don't want to do things. So when they are out of pain, then they realize, oh my gosh, I wasn't sleeping well, I wasn't doing this, I wasn't doing that. So yeah, it's I think humans, we are complicated, and everyone is different, everyone's got different motivations. There's no point to what I'm saying now, but yeah, it's very complex, and I think every experience molds you. So if you are like living in this experience of pain and it's made you scared to move, and it will make you not want to learn new things because it's too stressful for the for the system. It will make you not want to travel and experience new things. So yeah, it's detrimental to the brain if you are in chronic pain. So yeah, that's why I think there is such a wealth of practitioners out there, all different fields, and now there's even new age practitioners and new fields, and it's great. I think people are opening up their eyes to what health really is.
How do you react? Because I had a conversation with one person who we were kind of digging in, and it was like, if you didn't train hard when you were young, then you don't know what it is to train hard, right? And my son, as I'm kind of pushing him to train hard, he's like, it hurts as soon as I start running. I said, listen, Alan, you're a smart kid. What part of breaking down muscle sounds not painful, right? Because when you're training, you are breaking down muscle. Like, what part of that sounds not painful? How do you kind of manage pushing people who have never really pushed themselves?
I used to take personal offense when people didn't want to run like marathons after meeting me, So I think when I first started practice, you don't know what to recommend. You don't know what people adhere to. So you give lots of stuff, and people just get overwhelmed and they do nothing. So that's also where the NRE Protocol comes in, where we have to find where a patient can commit to starting something. So now we do it incrementally, So normally the fancy stuff on the social media might catch someone's attention. They want to come and see me in clinic, which is awesome. They're expecting to be given a block on the session 1 and shown like a penguin pelvis, and I teach them how to stretch their chest through a doorway to teach the shoulders where they actually should be. And then they're like, "Is that it?" I'm like, "Yeah, well, right now that's what your neck needs to be, more in the center of gravity, and right now, rounded shoulders. You can do as much exercise as you want. You're actually strengthening the bad patterns." And then they're like, wow, thank you. But yeah, speaking about exercise, my wife, when I met her, she had never done recreational exercise. To her, the education on exercise was bodybuilding and marathon runners, or people you see on TV. And then she hated PE at school. So she was never an exerciser. And that actually taught me something, because in South Africa, generally that's quite a active, mobile population. And when I met my wife, she's beautiful, she looks fit, she looks physically fit. And I was like, "What exercise do you do?" She's like, "Nothing." And I was like, "What? Why?" And she was just like, "Yeah, I mean, she's never been she's never been taught what exercise is or like why it's even good for her. And then I was like, wow, like there's one of the 5 brain pillars. There's 4 movement pillars that she's not even doing. And I'm like, wow, like there's a gap here. So that's where we have to be grateful now that it's popular to be healthy. And yes, there's a lot of noise around it, but I think people are moving. There are drugs out now that people can lose weight quicker, pros and cons, but if it helps people lose some weight and get moving, I'm not against it.
Yeah, I was actually just talking with my personal trainer this morning, kind of about GLP-1, GLP-2, and sometimes they call it GLP-3 retatrutide, and yeah, his thought process is, yeah, you lose muscle, and like, yeah, well, a lot of the people who really need a lot of these drugs aren't working out anyway, right? And if you just reduce calories, you're going to lose fat and muscle. So the key is so I think they can be really good tools. I got to ask, does your wife train now? I mean, you've got an 8-month-old, so maybe she's getting back. Like, how do you balance pushing your wife and maintaining a healthy relationship?
So she's a legend. She really does want to learn, and she takes my advice sometimes. But yeah, before baby, yeah, she had gotten into a little bit of a routine, doing some Pilates. She joined a gym. Yeah, so she was definitely moving. And yeah, now with baby, bless, extra sobby story for you. Our little one's got Down syndrome. So yeah, there's just lots of extra things happening. So her life is exceptionally busy. She lets me be productive with work. I'm very grateful for that. But yeah, her life is busy. So whenever I can, I take the little one for a walk and give her some free time. And she might just get some red light. She might have a sleep. She's starting to do some exercise. She can see that puts a smile on my face, which is also good for her. So yeah.
No, it's really cool, because you have every excuse in the world when you have a young, almost toddler, right? Like you have every excuse to like not work out. She got enough of the bug before pregnancy to really appreciate that and do that again. You talk about movement is medicine. What physiological changes are you referring to when you help people reverse pain and dysfunction with movement?
Yeah, so I think movement is just it's the end result of a brain thought. Like if your brain thinks about something, it is able to do that thing through movement. So movement is just, yeah, like if you look at people who are paralyzed, there's just so many health issues around that because they physically cannot move. So if you can physically move, yeah, it's how the body expresses itself, Like if you're stressed, your body sighs. That's a movement, like your body's forcibly inhaled some oxygen and it's off and it's dumped carbon dioxide. But it's a movement. So yeah, I think everything is brain and movement is the end result of a thought. So yeah, like movement really is just everything, I suppose.
And then it ends up reversing, in your case with your protocol, it ends up reversing kind of the pain and dysfunction because you're reprogramming that neuromuscular system, right? So it's this collection of stimuli. So when you say stimuli, and you kind of referred to this, alluded to this or stated it, you're using other modalities. So one, you've mentioned the penguin, right? So you've got penguin to help assess the back, but you're also doing some other stimulus. What other stimuli do you use?
Yeah, so in clinic we use manual therapy, as in so like me personally, I do a lot of my fascial trigger point release. Yeah, so fascia is fascinating. We could do a whole podcast about just fascial stimulation and fascial treatments. We use acupuncture and dry needling. Again, that's all neurological effects, but obviously it is sticking needles into people, but the effect is all very powerfully neurological. I have got a few modalities like the TENS, the IFCs. I've got the red light now, which is I'm having some fun with that. So yeah, all of this is just, let's see what the patient would respond the best to. Even the manual adjustments. So like physiotherapists, osteopaths, chiropractors, we can all do joint mobility stuff, depending on how much force you put through a joint, it's either called an adjustment or it's called a mobilization. But if you mobilize a joint that's not moving, that restricted joint hasn't been giving the brain stimulus for a while, and or the muscles around there have been telling the brain spasm, and they've never been taught how to move again. So physically moving the body as a treatment is great. It's teaching the brain how to move again. And then that's in the right context. Just a random treatment or a random anything feels nice short term, but essentially it's just trauma to the brain, and the brain's going to feel great because you physically got the body moving a bit. But if it's like a once-off thing, sometimes the long-term effects are actually zero. So that's where working alongside someone as an accountability partner, you just get the best results, and you go from having pain and dependence, and you go to optimization and check-ins.
And you do some coaching, right? Is that correct? Do I remember that accurately?
Yeah, I do offer that, but at the moment now it's pretty much just full-time clinical work essentially, and I'm trying to have one day a week where I'm just creating content. But that doesn't happen. It's one day a week now is basically just helping my wife.
Oh, yeah.
So yeah, life is busy at the moment, but hopefully it'll start to normalize a little bit. We'll see.
Very cool. Now, so what foundational movement patterns do you think every human should master to stay mobile and to stay injury-free as they age?
Yeah, it's a big question. So I think everyone should learn a little bit and know what those 4 movement pillars are, and see where you might personally need to be doing a bit more. So yeah, like just one clinical example, have a patient goes to the gym, mega strong, like trains hard strength exercise, but then might be doing no endurance whatsoever. And then he's constantly hurting himself, getting tennis elbow, etc. And maybe that elbow is just used to doing power and hitting a tennis ball or powerful movements. But as soon as it goes into an endurance stimulus, the brain protects it, causing pain. So yeah, I think everyone should just kind of look at the 4 pillars and see where they could potentially introduce some movement as a habit, and something that they can commit to sustainably, and start there.
Are there any kind of mistakes that people tend to make when it comes to movement that sabotages their long-term mobility?
In a clinical aspect, I work a lot, and we speak a lot about posture, right? So posture is, again, like just a big, broad topic. I think posture is often misunderstood. To me, the definition of posture is placing your spine in a healing environment. So if posture is a factor for someone's spinal related pain, that's pretty much phase 1. And often there might be just a forward dominance to a posture without knowing it. So we might give some movement patterns around restoring some natural posture again. So I joked earlier about the doorway stretch. That's a big one. Glute mobility. Many people are tight in their glutes. And then hip flexors. Right now I'm sitting. Yes, I'm sitting up straight, but I'm sitting, so my legs are flexed in front of me. And a lot of us do that a lot. And even your hip flexors might be slightly tight or weak or restricted, which means when you stand up, all your back muscles are doing so much work all day, every day, just to keep you mobile. So yeah, so again, I think we mentioned earlier, people are complicated. Everyone's got a story. Everyone's got different mechanical issues. There definitely isn't a one size fits all. And that's the excitement of working. Clinic, it's also the stressful part, I wish that there was a general program for everyone. Or I wish I could fix someone in one session. I'd be very rich, but people would have to get a mortgage, right? But yeah, there is no quick fix for anyone. It's a journey.
So as we're kind of wrapping up here, think about if there's anything we didn't we'll get to our wrap-up questions, if there's anything we didn't really touch on that you wanted to, and also maybe one more story where do you get, I'm trying to think, I had a question earlier where you've got, I don't know if you get MRIs on everybody. So that's one question, right? So where you have this compare and contrast of this MRI looks bad, but they actually aren't reporting pain. This MRI looks fine, but they are reporting pain. Do you see any patterns there in kind of mindset, overall mindset, like maybe negative mindset, positive mindset? And is there anything that you try to do to help in that area?
Yeah, so I suppose in my ecosystem, I'm seeing people who are in pain generally, and
Yeah.
therefore they've had an MRI to identify that. So I think it's just the degree to which you find things. So most people would have some kind of structural thing that they found, but then the advice around that is very broad and different depending on which kind of practitioner you would see. So yeah, I think in general, there is just a lot of dependency out there where people feel like they almost have to see people, and that's fine. I like to work with people over time, but I often teach patients, I would like you to come back and see me regularly, as spaced out as you like, but you want to see me. And you understand that it's optimizing your body. It's not that you need to see me because you need to see me, otherwise you'll be in a wheelchair. So it's a fine line. We just want to try and tilt the seesaw into positivity and the patient being able to self-sustain as opposed to dependency on a certain person.
Yeah, I like that, trying to get them to the point where they're not dependent on you. Before we get into our wrap-up questions, is there anything that maybe we didn't touch on that you would like to share?
Nothing off the top of my head. We'll have to do an episode again in the future.
Yeah, no, that sounds really good. All right, let's get into our questions here. Do you have a target age that you want to live to?
80.
80. And Dr. Wayne, how long do you think humans can live?
Yeah, you did send me these questions earlier, Chris. Thanks. I have no idea. I think people who might, like, I think the centenaries is out there, and people talk about living longer. There is an asterisk to that. You know, you might outlive everyone around you, but then who are you going to share your life with? So, it's a little bit of a philosophical question. I believe God's got my day written in his book. I'd like to get there as healthy as possible and as functional as possible. I would like to pass on able and functional versus not. There's a controversial statement for you.
No, I like it. No, that we actually get that a lot, where people are like, I don't care how long I live as long as I'm able-bodied, and then I like to push them and say, so, but you're able-bodied now, you don't want to die tomorrow. Like, what's the date?
Yeah, that's true. That's true. Yeah.
And you already gave it 80. So, Dr. Wayne, what are 2 to 3 protocols, habits, mindsets? Let's call them shortcuts, because everybody likes shortcuts to longevity and a long health span that you would share.
Yeah, I think Huberman's the expert on this one. Morning sunlight viewing. So I make that a priority, get morning sunlight in my eyes. I can see the benefit of it. The science backs it up sort of very strong. So morning sunlight is a big one. Find a movement habit that you enjoy and that you can do sustainably, ideally outdoors, but find some kind of movement habit. And I would say do whatever you can to get as good of a quality of sleep as you can.
Very good. Are there 1 or 2 things that you think people get absolutely wrong regarding longevity and a long health span?
I think people often think that there's a simple fix or a quick fix or a hack. So the word biohack is just like one of those words, right? Where I don't like it, but I do like it. There is no one thing for all. My education, I would like to just get people and motivate them to get back to the basics, to those five brain pillars of an enriched, healthy brain. So I think the best biohack would be for an individual to find out where they are most lacking in the 5 pillars and start introducing those as soon as possible.
Excellent. Dr. Wayne, how can people contact you?
movemed.co.uk is the website, or my social handle is movemeduk.
Excellent. And what in the near future are you excited about?
Family time. I've got a nice holiday to South Africa to go see my South African family, and I'm turning it into a real sabbatical, so I'm looking forward to that.
Excellent. All right. You can find Dr. Wayne, MoveMed, that's MoveMed, movemed.co.uk. That's his website, on socials, which are blowing up. MoveMed is the handle there. Dr. Wayne, thank you so much for joining us today.
Thanks for your time, Chris. I appreciate it.
I hope you enjoyed this episode of the Live Beyond the Norms podcast. make sure to subscribe and follow. Also, make sure not to be that guy, the guy sharing this podcast with people who are not interested in living beyond the norms. If you would like to learn more about the ESS60 molecule, the molecule responsible for the single longest longevity experimental result on mammals in history, a full 90% extension of life, visit myvitalc.com. That's myvitalc as in carbon.com.